Good morning. Welcome, everyone. Our session today is Caring for Patients in Communities Experiencing Homelessness. I am Ann Cottingham. I'm a health services researcher with IU Health and with the Evans Center for Spiritual and Religious Values in Healthcare, directed by Dr. Lexi Torkey. The Evans Center is co-sponsoring this event with IU Health Chaplaincy and IU Health Spiritual Care. I'm joined today by my partner in this work, IU Health Chaplain William Taylor, our colleague Gloria Robertson, also with the Evans Center, who will be directing the administrative portions of this program, and our panel of experts, Kay Wiles, Director of HealthNet Homeless Initiative Program, Leah Hicks, Senior Program Manager with the Corporation for Supportive Housing, Joe Gordon, Senior Program Manager with the Corporation for Supportive Housing, and Dr. Chelsea Herring-Cozy, Executive Director of the Coalition for Homelessness Intervention and Prevention. Now I invite Chaplain Taylor and our expert panel members to go ahead and introduce yourselves. William, I think you're muted.
Back. So again, I said, thank you, Ann. My name is William A. Taylor III. I am the Director of Chaplaincy for the Indianapolis Suburban Region, which is the northern section just north of Indianapolis. And I'm serving in this capacity with my colleague, Ann, and really looking forward to this conversation. So I'd like to say again, welcome.
And I will gladly kick off the panel introductions. Hello, everybody. Great to be here. My name is Joe Gordon, as Ann mentioned. I'm a senior program manager with the Corporation for Supportive Housing, native of New York City, but have been in Indianapolis since 2006. So at this point, I think I can consider myself a Hoosier. Wanted to kind of set the table of how we're going to approach our panel discussion today, and wanted to share some quick slide before kicking it over to the other panelists on some agreements. Let me navigate this here. Okay. Oops. So before we get into the rest of the panelists, I just wanted to share our community agreements for this discussion. We're hoping that everyone can, move at the pace of trust. We're going to be sharing some information that you might not have considered before. And so just assume the best of what we're sharing, that it's for your benefit and the benefit of your organizations and your communities. We want to try to define transparency throughout this process and highlight that transparency is of the utmost importance in all the conversations that you have and the goals you're trying to achieve. Trying to promote collaboration. No one knows everything, but together we can know a lot. And so I think tapping into those community partners, team members that you might not have engaged before is something that we're highly encouraging you to do. Rather than judge, turn towards curiosity. Again, we might be introducing some concepts that may be new to you, and might rub you a certain way. If that happens, lean into it and try to find out why that is, and then sit with that discomfort whenever it comes up. Being authentic and avoid being transactional. I'm trying to get out of this presentation mode. Looks like I'm having some Zoom issues myself, but with that said, I'll go ahead and kick it over to my colleague, Leah Hicks.
Thanks, Joe. Leah Hicks with Corporation for Supportive Housing here in Indianapolis. I've been with CSH just over 5 years, and prior to CSH, I worked for a local community mental health center for 27 years, providing services and supports to persons experiencing mental health and substance use disorders, as well as those experiencing homelessness. So really excited for the conversation today. And I'll pass things over to Kay.
Hi, good morning. Thank you. Thank you, Anne and William and Gloria, for this opportunity. My name is Kay Wiles. I work for HealthNet's Homeless Initiative program. I grew up in Indianapolis. I think usually when you grow up in Indianapolis, people ask what high school you went to. So I went to Cathedral, so everybody knows. And I have a long history of working in this field with inpatient psychiatric work. I have run a men's homeless shelter and have done a lot of work on housing and street outreach. So I am really happy to be here to share what I've learned and how we can work together to support people in need. So thank you for being here. And I will pass it over to Chelsea.
Thanks, Kay. And thank you, Anne and William, for inviting us to join this important conversation and group today. We're honored to be here with you all. My name is Chelsea Herring-Cozy, and as Anne mentioned, I am the current Executive Director of CHIP, the Coalition for Homelessness Intervention and Prevention, and have served in that role for the past 6 years. I grew up in Michigan and came to Indianapolis by way of Chicago back in 2016. My roots do go back to working in the homeless service sector a couple decades ago in case management, and then took a little detour into academia where I taught a lot on issues of housing and the intersection of housing policy, criminal justice reform, mental health, and have been really honored to be back in community-based work here in Indianapolis. So excited to be part of this conversation. I want to share a little bit, and I think the panelists are going to do this as well, about my why and why this topic is important, why this work is important. And that is, really coming from a place of housing as fundamental to everything. Housing is foundational at its core. It's a place for safety. It's a place for connection, for wellness, for healing, for stability, and for dignity. And it is my firm and core belief, based on, how I was raised, how we were brought up, that everyone deserves that. Everyone deserves to have that foundation, that place of safety and stability. Our home growing up was that for us and for many others as we took in family and friends that had challenges in maintaining housing or maintaining relationships with those that they were in housing with and needed that network and that safety net. And not everyone has that. And you see the consequences of that, and it just reinforces, again, housing as a core and fundamental right that everyone should have access to. And so really excited to talk with this group more about that and some of those values and how we try to get to that place. Oh, you're on mute, Anne.
Thank you. We are a large group today, so we invite you to turn off your microphone and your cameras, other than the panel members, and to share questions or comments that you have through the chat function. William, Gloria, and I will be monitoring that, and we'll be sharing at appropriate times your questions and thoughts during the presentation. So thank you all for joining. We're delighted that you're here today, and we'll just jump right in with our panel members.
Guido, do you have any additional framing, or are we jumping into the?
I do have additional framing. I'm trying to navigate the sharing option on my screen. Give me one moment. Is it currently sharing for you all?
Not yet.
It's not. Okay. Give me one moment. I'm not sure why that's.
Sometimes there's an additional share button on your, like you hit the share at the bottom, and then when you click the PowerPoint that you want, and then there might be another share on your lower right of your Windows screen.
Okay, because it did. It's giving me the screen I want to share, but it's not.
There you go.
It's there.
Okay, great. I want to show you all my notes. Okay.
Nope, we see your notes now.
You see the notes?
Yes.
Okay, I'm sharing the wrong screen then. Forgive me, give me one moment.
Always works in practice, right?
Because right now I'm like shifting through all of this in the wrong order. Sharing. Okay, well, as I'm trying to navigate this, what I can tell you is that the focus for this panel is going to be turning your why into action. Chelsea shared her why as to why she's engaged in this work. We're making the assumption that you're all here because you care about folks who are experiencing homelessness and how your healthcare systems may be able to assist them on that journey. And so Chelsea's going to open us up with housing as healthcare and tell us more about what the state of homelessness is in Indiana. Kay is going to follow that up with the importance of a person-centered approach to ending homelessness, treating the person and not the disease. Then Leah is going to share some information about the positive impact of permanent supportive housing and housing first and achieving health and wellness for folks who are experiencing homelessness. And I'll touch upon considering the benefits of shifting from a trauma-informed approach to a more healing-centered approach in healthcare, and then also touch upon the concept of targeted universalism as you all look to improve your processes in helping people along this journey. And then we'll close out with asking you how to consider starting future conversations with partners and engage you all in what thoughts you may have that might have come up during this discussion. And with that, I'll kick it over to Chelsea.
Thank you so much, Gijo, for laying that foundation. And I do want to ask if everyone can see this as a slideshow.
Yes.
Yes? Okay,
Yep.
fantastic. Okay, so my goal this morning is to just lay a little bit of shared foundation. So we're all coming into this conversation with some common knowledge and agenda of really what the state of homelessness looks like here in Indiana and specifically in Indianapolis. I do want to kind of frame, we're doing a lot of framing, but things I want you to kind of keep in mind as you approach the conversation today and listen in. And this is a really great reminder from an advocate and really important political figure, Stacey Abrams, who really helps me orient our work. And that is that we are strongest when we see the most vulnerable in our society, when we truly bear witness to their struggles, and then we actively work to create systems that make things better. It's often the systems of care that we set up often with the best intentions, but that don't always serve people in the ways that we had hoped or would like to see. And so how do we really approach our work from that systems lens, but keeping people at the center of it? And so as you listen today, I really challenge you and encourage you to think about your work and reflect on the ways in which your perspectives, your practices, the policies that you operate in either contribute to creating more effective, equitable systems of care, particularly for some of our most vulnerable neighbors, or contribute or perpetuate systems that continue to further inequity, disparities, and vulnerabilities. Because our work, as you'll hear today, is not done in isolation. It is part of a much larger continuum or system of care that either has the power to dismantle barriers and serve people well, or hold up inequities and perpetuate those barriers. And so as we approach the conversation today, I want to share some of our common goals, vision, and values within the Indianapolis kind of homeless ecosystem. The way in which we think about approaching and addressing homelessness is with the goal in mind of making homelessness rare, brief, and non-reoccurring, meaning experiencing a housing crisis shouldn't automatically lead to a homeless experience. We should have good safety nets and practices in place to prevent people from experiencing homelessness, which compounds trauma. It should be brief, meaning if people do have a homeless experience, it should not take a long time to get back into a place of housing and stability. that there should be quick action for folks coming into shelter or in unsheltered circumstances to get them back into better places of healing, stability, and wellness. And once back in those places, we don't want people coming back to shelter or experiencing homelessness, because there's a good system of care and network of support to help with that stability. We firmly believe that everyone has the right to be housed and connected to care. And at the heart of that is a fundamental belief that housing should be a human right. That's how foundational and important it is. Unfortunately, we don't treat it that way in this country right now, but that is at the core of our work. And we demonstrate that through a practice and a model called Housing First. You must treat someone's housing crisis first before you can even think about what other things we should be focusing on. Long-term health and wellness, employment, and better wages. Without that housing stability being addressed first, it is impossible for folks to focus on other issues, honestly. And so how do we really lead with that approach and having low barriers to housing? You'll hear this a lot today. Everything we do has to be person-centered. So even how we talk about people experiencing homelessness, you will notice I say person experiencing homelessness. At the front of this, we're recognizing the person and the experience they're having. And that's different from saying, oh, a homeless person who puts their circumstance first and their person-centeredness secondary. We want to flip that. So I want you to think about that too in your own language and how you're centering the human and then talking about the experience that they're having. They are not their housing situation. The reality that we face though right now is that homelessness is persistent in our community, in our state, in our country. It is increasing in several ways, and it's complex, and we cannot address it alone. So this is an important conversation to have with our healthcare partners. As we think about the problem of homelessness, one of the things I want to orient is that homelessness is not an individual level issue. It is not a failure of people. It is not a result of bad decisions or broken humans. It is a structural and policy issue. Homelessness, as we know it today, is the result of policy, and oftentimes bad policy that has disinvested in public housing, that has disinvested in community care. It is the result of a lot of systems that are not working well together or not effectively serving those that have barriers and high vulnerabilities. It is the result of ongoing racial discrimination and exclusion from a lot of systems of care. And at the end of the day, it is a housing problem. Housing, as you'll hear, with care is how we solve homelessness. Shelters are vital. Shelters are life-saving. They are not solutions to homelessness. This really is in large part a housing challenge and issue. I want to talk a little bit, and this is simply a snapshot. So if you like data, reach out to me after this and we'll provide a lot more data. But let's talk about who then is experiencing homelessness. And I want to give a perspective from national level on down to local. This is based on 2023 point-in-time count data. And point-in-time count, for those that do not know, is a single night snapshot. So think of it as a census, a one-night census of who experiences homelessness on a single night across the country, across the state, and in local communities. It is the only comparable data point that we have nationally. So what that looks like, and we have more updated local data, but the national and state data is lagging a little bit. So I use 2023. Nationally, there are about 650,000 individuals experiencing literal homelessness on a single night in this country. And I say literal because that means folks that are staying in emergency shelter, transitional housing, or in places not meant for human habitation. This does not count people who are doubled up, couch surfing, or largely housing unstable. This is literal homelessness. That has increased nationally. Homelessness is increasing nationally. At the state level, so this includes every county outside of Marion County, there were a little over 6,000 people last year on the single point in time count night experiencing literal homelessness across this state. This is important to note because oftentimes homelessness is talked about as an Indy issue, an urban issue, and this affects every community and county across this state. What that looks like in Indianapolis on a single night last year, and it's slightly up this year, there were a little over 1,600 individuals experiencing homelessness on that single night in January. Things to note, and again, we can do much deeper dives another time. I'm just trying to lay a foundation here, but things to note about homelessness. In the last 10 years, overall homelessness has trended downward, but we've seen some upticks in recent years, particularly coming out of pandemic times. But while the aggregate of those experiencing homelessness has been trending a little bit downwards with some recent uptick, the two areas we're paying most attention to that have seen significant increases within that aggregate are those who are experiencing unsheltered homelessness. That is increasing nationally, statewide, and locally. So more folks are staying in places not meant for human habitation, which has huge implications, again, for health indicators and outcomes and access to health care. And those who are experiencing chronic homelessness have increased. And chronic homelessness is a category defined by the U.S. Department of Housing and Urban Development of folks who have had long-time homelessness, 12 or more months consecutive, multiple episodes reoccurring of homelessness, and disabling conditions. So folks that have pretty high vulnerabilities in terms of chronic health conditions, behavioral health, mental health. And so different interventions, and these both indicate the vast importance of having closer partnerships with healthcare systems. Another area to note is that homelessness disproportionately affects communities of colors, and specifically Black individuals and families. So while in Marion County, for example, only about 29% of the Marion County population identifies as Black, more than half of those, over 53% of those experiencing homelessness, are Black households. And when we further disaggregate that by family, it's upwards of 60 to 70% of those experiencing family homelessness are Black families. So racial disproportionality is significant. And this, again, gets into how our system's designed to be more equitable, inclusive. What we also see that's important, I think, for this group to understand is that those who are experiencing unsheltered homelessness are often disconnected from consistent healthcare services. You'll hear from partners today, including Kay, what's happening to really try to bring healthcare to those folks, meeting folks where they are, but it's a big challenge and gap in how you really connect these systems. We're also seeing a growing aging population of people experiencing homelessness, again, which have really unique and specific kind of health needs to address those of more aging populations. So that's a little snapshot. Again, please follow up if you'd like some additional data. I also want to kind of lead this group with a shared understanding of what we see as the key drivers of homelessness. Of course, we talked about homelessness not being based on individual level factors, but really systemic factors. And this really helps, I think, solidify that point. Homelessness is driven, again, by housing markets. What does the housing market look like in the community? How high are rents? How much are rents increasing in that community? And what are policies around tenant rights and protections? Because all of that speaks to, can people access housing? Can people that afford it? Are there high barriers to accessing housing in terms of tenant screening policies? You know, when people experience a crisis, how easy or hard is it to get back into housing? And housing markets really drive a lot of that. So you can see some stats here. I won't read them all to you, but we have significant challenges in our community in terms of rent burden. Indianapolis is one of the communities nationwide that has seen the largest rent increases in the last 2 years. We are among the top cities across the country experiencing those kind of rent increases, and wages haven't kept pace. And so you'll see on the screen a really important report that's done every year by the National Low Income Housing Coalition that says, what would it cost or what would it take wage-wise for somebody to make to afford just a fair market rent in your community? And what that looks like in Indianapolis is over $25 an hour. We are far from that in terms of what folks are making. And so huge gaps in terms of wages and housing costs that really help continue to drive what we see in terms of homelessness. And again, I want this to be an important note because of course, people experiencing homelessness may struggle with substance use, may have untreated or undiagnosed behavior or mental health conditions, may have chronic health conditions. And while those definitely become complicated and are persistent in their experience of homelessness, they're not the driving factors. Because people in housing are also experiencing those, but they're able to engage healthcare differently and in more preventative and consistent ways. And so those are not the things that are driving or keeping people homeless. It really is about these structural factors. So let's talk about some of the impact of this, because homelessness has significant impacts on folks. Homelessness drives healthcare outcomes in really, really negative ways for those experiencing it. Housing is a driver of health, and I hope you all hear that and embrace that, but we see that every day. Experiencing homelessness has a negative impact on people's overall health and life expectancy. And this is just one data point that shows people experiencing homelessness, life expectancy, particularly the longer the homeless experience is more than 20 years less than the average population. Simply because of their homeless experience is exacerbating health conditions and really, really driving that life expectancy much lower, almost back to what it was in the 1900s. That is concerning, and it is something that can be corrected for. Homelessness is traumatic. It contributes to and exacerbates chronic health, mental health, and behavioral health conditions. People living unhoused cannot effectively heal, recover, or engage in consistent and active care, which is again why housing first is critical. And healthcare utilization looks very, very different when you're experiencing homelessness, meaning oftentimes folks experiencing homelessness are utilizing emergency department use, high utilization of emergency rooms and EMS, and oftentimes have a lot of unmet healthcare needs that don't get met until it has become crisis mode. And the goal is to really shift that to more preventative and primary care to be able to move away from crisis health to, again, more consistent preventative and primary care. Housing is not just healthcare, but it is also a social and racial justice imperative. So as I mentioned, there's significant and persistent racial disparities in terms of who experiences homelessness. And we often see this related to other system engagement too. So homelessness can contribute to involvement with justice and legal systems, which can exacerbate barriers and trauma. And justice systems also contribute to homelessness, further exacerbating racial disparities and disproportionality. We also can see that in terms of utilization of healthcare or lack of utilization of healthcare systems, also contributing to some of these inequities. And so where I'm kind of hoping to start to transition to my colleagues and fellow panelists is this foundation of housing really must be treated as a human right. And when we think of housing first with quality service and care works. When we see it done well and integrated with other systems, it works extremely effectively. And that's what we're trying to achieve. And those in healthcare play a vital role to this work. So with that, I'm going to stop sharing and I'm going to transition it to Kay to talk a little bit about more what this looks like from a kind of personal level and from an on the ground perspective. Okay.
All right, thanks, Chelsea. That was great information. So at the Homeless Initiative Program, we offer medical services to those who are homeless. We are part of a federally qualified health center. We receive funding through healthcare for the homeless and other support for our work that we're doing in Bloomington as well. So we have a team that goes out on the street to provide street outreach. That's in partnership with many community partners. The goal of those outreach workers, it's called professional blended street outreach, is truly to identify who is on the street, to build rapport with people so that when they have a need, they have a trusted person to ask for assistance. And the basis of that work is that no one dies on the street, although that happens much too often. So through that street outreach, we know that those folks are building relationships with people on the street, and we have a nurse practitioner who goes out with them one afternoon a week is all we're able to provide at this point, to see people on the street and provide medical services. We have a nurse practitioner and a medical assistant that also set up clinics in all the shelters in our community so that we're taking medical care to them in the shelter. And then I would say our work in Bloomington is really the most exciting and cutting edge at this point. We're trying to provide what is known as street medicine, really having a nurse practitioner and a psychiatric nurse practitioner on the street to provide those services to people on a daily basis. So the goal of our work, I guess the why of our organizational work in the medical arena, is to reduce the cost to taxpayers and the burden to emergency rooms and emergency personnel by providing those services once they get to a crisis level. So trying to provide them in a way that stops it from moving to a crisis and allows more dignity while providing that service. I'll say that when we get our nurse practitioners, there's a lot of training to really slow down the service as they offer it and to see the person, to allow for some trust building, to understand what homelessness means. I think as you see people in the work that you're doing, I'm sure that you see people who are unhoused, you see people who are doubled up, you see people who don't have the resources to meet all the needs and recommendations that you may be offering them for better care. Our medical team understands that from the beginning, and so we try to provide services in a way that those barriers are understood and removed at the beginning. I think it's hard. We know that when we're seeing people, we aren't seeing them at their proudest moment. We know that sometimes they have on clothes that they've had to wear for a long time. And it's hard for people to raise their head up and have dignity when they're in that state. So I think it's hard for people to follow through with all the recommendations made. It's hard for them to make appointments as necessary because of some of those barriers. When we're treating people and making recommendations for next point of care, we already know that folks are unhoused, and so we try to have those tools ready so that the barrier is already removed. We try to carry medications, give them medications when we see them. We will go to pick up medications and find them and take the medications to them. We try and track people using our outreach team so that we don't have to use telephones or schedule appointments. So I know that as you're seeing people in your clinic or in your medical space, to have to ask the question, are you unhoused, is uncomfortable. And people may not answer honestly because that's a tough question. It's not one that comes with pride. And so trying to get at how, what do people need in order to carry out the recommendations that you're giving them for better care, I think is a great thing to understand without having to ask, are you homeless? So if you're going to offer medication, you know, walking through how they're going to get that medication so that you're clear they have the steps and the ability to do that, that next level of care that you're recommending. I will say that our providers, as they learn to treat people on the street who are homeless, they have to look at the trauma. They understand that often trauma led to homelessness, and there is trauma once we lose our housing. And so knowing that that is a bottom line for the care that we're offering, I think is very important. We, again, try to see the whole person and not just their illness or their complaint. We try to take the time to listen and understand the whole need. I want to share a few pictures. My slides are not as nice as Chelsea's, but can you see them? Okay, I'm always confused about what you are seeing. So the first are pictures of camps. So these are the conditions that our team will go out to provide care. Some of these camps are amazing to go out and meet people where they are. The amount of creativity and ability of folks to make a space that feels like home for them has blown my mind for all the years I've done this work. People are very creative. So I'm going to pop down to some more pictures real quick. So these are, this is our nurse practitioner, Abby, treating someone in their tent. She was able to do blood pressures on folks. She's able to do labs to understand needs. Over on the right, she saw a gentleman who had stitches in his toe for way too long. He wasn't able to get back to the emergency room to get the stitches out. So when we identified that they were there, Abby was able to take those out on a log out in the woods. Here's a picture of Abby treating somebody who had a face wound and the same kind of issue, wasn't able to go back to get the stitches out and the next level of treatment. So Abby was able to provide that service on a park bench, and then followed that gentleman for several days and weeks after in order to make sure that the wound was healed thoroughly. So we know that taking that care to the street is more direct. It is a savings to taxpayers, and is just easier for those that we serve to access. I'll pop back up here. Chelsea was talking about the undue burden and illness when we lose our housing. You can see the numbers there that diabetes is almost doubled for folks who don't have housing. Hypertension is almost doubled, heart attacks, and then the HIV, hepatitis C, depression, and substance use disorders are all tremendously impacted. I want to highlight that I think that people often think that substance use leads to homelessness, and it does in some situations. But what we also know is that once we lose our housing, living on the street or living in a homeless shelter is traumatic. And a lot of times people use substances in order to manage that anxiety, that depression, and just their daily existence. And so it's not always the cause of homelessness. Sometimes it's the reverse of that. And I think that that's important to understand. When we talk to other providers, we try and help people understand thinking through what your policies are and the services that you provide, and how those can be a barrier for people who don't have housing or who just have limited resources. So some of the things that we help people think through is a normal clinic policy on no-shows. Oftentimes when people no-show, they get 3 opportunities to no-show, and then they are no longer a patient and have to start over with that service. I will say HealthNet does have clinics, and we try to get our patients tied to a clinic if they want to do that. And sometimes what we do in that transition, we'll walk them to the clinic to meet the provider. We also will sometimes double up on appointments, so the provider doesn't lose time, because we know that provider's time is expensive. Insurance doesn't pay for missed appointments. And so then the provider will know that they may have to double up on an appointment until we're sure that that patient feels comfortable and confident in moving through the clinic, if that's what they choose to do. We also work hard about how are patients notified of appointments, and how do patients get medications. I think these are really difficult things for people who are unhoused and keeping appointments. And then, yeah, scheduling just overall is usually a common barrier. So I'm going to stop sharing those. So while we provide those services and hope to have a conversation a little later on today about barriers and how we can work together to remove those, I will also say that supporting the work of street medicine, or making sure that we can provide services on the street to those who are homeless, is a smart and cost-effective way to care for people. And it's expensive, but it's not as expensive as not providing it. It's not as expensive as not housing people. We know that both of those options are more expensive. So thinking through how you can support that kind of service care to reduce burdens and barriers on both sides of the fence, I think is really important. As we treat people on the street, especially I'll say our psychiatric nurse practitioner in Bloomington, building rapport and trying to break through people who are highly symptomatic and on the street takes a long time. It takes persistence and consistency. We have been able to get people to start to take medication, and then from there, reducing their symptoms and able to get people into housing, which I will say in Bloomington has made a difference in that community. We have heard from just citizens in Bloomington who have wondered what happened to the gentleman who was on the street always yelling at traffic. I think he was known in their community for 8 years, and we were able to make an impact on that gentleman's care by introducing medication that we supported with daily appointments, daily visits, and then realized that he had a brother who had been looking for him for years. His brother was in, I think, Nebraska. With his permission, we connected him back to his brother, and his brother sent a plane ticket for him to fly home, and he is now living with his brother and connected to care. That took a tremendous amount of work and time, but wow. I mean, I believe that there's dignity in that so much for that gentleman, but I think also for the community. I think it reduces all of our dignity when we walk by people on the street and don't see them and don't acknowledge them and don't own that as part of our issue as a society and a community. We know that we're all stronger together. So I'm a big believer in that work, and that is my why. I cannot walk by people and not do something about it. So with that, transitioning people into housing, we know is important. And Leah Hicks is going to talk to us about best practices around housing first and what those strategies look like. Thank you.
Thank you, Kay. Good afternoon, everyone. Yeah, to transition from what Kay is saying, kind of about the why. You know, I've certainly learned over the years that you can't make assumptions about where someone can go and what someone's potential is, because I've been proved wrong many times, and I'm so thankful of that. And it takes all of us to, as Kay was saying, see that person and recognize that with supports and with care and listening to them about what they need, that recovery from whatever is happening in their lives is possible, and stable housing is possible. And so it's just always been important to me to keep that in mind, that that person that I'm connecting with, I have no idea about their history, and I also don't know anything about their future, but I can be there for them currently and provide those supports, and then it's sort of providing that soil to watch people grow. So as Kay said, I want to share some information with you about supportive housing. And let's see. Are you seeing my slides, I hope? Yay, let me all right, perfect. So, yeah, transitioning and talking about supportive housing and housing first. So that's been mentioned a bit already today. We know what works. We've got lots of research and data that tells us and shows us that supportive housing and housing first is the model that helps persons exit experiencing homelessness and move into stable, affordable housing that provides those supports that help them move forward in thriving in their communities with dignity. And that's really what supportive housing is all about. It's taking the element of affordable housing. And so when we talk about affordable housing, we're talking about providing and connecting people to rental assistance and subsidies that make it so that they're not paying any more than 30% of their monthly income on their monthly rent. So there's lots of different ways that can happen through vouchers and different HUD programming and things like that. We won't get into that, but there's a lot of different ways in which we can provide subsidies to help people with that affordability component. And then the second component is the supportive in supportive housing. And that's really connecting people with an array of services that meet their needs. So it's flexible, it's voluntary services that help them identify, these are the things that are going to help me not only obtain housing, but to maintain that housing. And that's sort of the basic fundamental definition of supportive housing. And, we're again really focusing on creating a platform in which people can, as Kay and Chelsea have spoken about, that trauma of experiencing homelessness, being able to come into a safe housing situation and now start to feel as though you have some safety and some ability to now identify what are those basic needs, right? And so kind of parallel to when we talk about supportive housing, we talk about housing first. And so sometimes those are used interchangeably. Really, I think we've got like supportive housing as a structure and housing first as an approach. So you will often hear them used together, and we talk about them together. And housing first is about quickly housing people who are experiencing homelessness. It's not about looking at well, what's the situation? What have you done? What have you not done? Where are you at? These sorts of things. It's identifying you're experiencing homelessness. Let's get you housed. And it's not about a temporary housing situation. It's about getting people into a permanent housing situation that meets their needs. Again, we infuse choice in that. What works for you? What needs do you have when it comes to housing? We all know that if we aren't provided choice in decisions that we're making, then those often aren't lasting situations. So that happens with housing too. Even though someone is experiencing homelessness, we shouldn't assume that they should just take whatever we have to offer. Instead, being thoughtful about what type of housing do they need, what area of their community or what community. So a lot goes into thinking about this, while we're also saying let's move people into housing as quickly as possible and reduce that trauma. We've mentioned housing first and supportive housing is that platform. So now people have the opportunity to really think about and pursue those personal goals and improve quality of life. Meeting those basic needs now that one is housed. Now I can, I can get my food, I can get to where I need to be. I can start thinking about managing the healthcare issues that are happening in my life that both Kay and Chelsea have talked about, and how much not necessarily easier, but we can do that, or a person can do that when they're no longer unhoused or in encampments or even in shelter for that matter. Case management and services, again, that voluntary, flexible array of services that are provided to a person or available to a person. And housing is never contingent on participation in services. That the housing does not come with strings attached. It's you're unhoused, let's get you housed. And then case managers and service providers really focus on engagement around working with people, building that trust, and helping them make those connections to the different healthcare and services and systems that they need then to continue to successfully maintain their housing and pursue those goals. And again, not everyone is going to hop into housing and then say, I can't wait to attend all these different appointments, and now I'm super ready for medications and these sorts of things. So we work with the person where they're at in both identifying what their needs are and how we can help them access those services. And then really using a harm reduction approach. And so again, it's meeting people where they're at, helping them to identify what are the harmful things that are going on in their lives. And it could be harmful behaviors, it could be harmful relationships, it could be, harmful surroundings. all of those things, and then working with them to employ strategies to help them reduce those harms. And that taking medication can be a harm reduction tool. Different services themselves can be harm reduction for folks who are experiencing symptoms of different maladies, if you will. It could also be teaching people how to use Narcan, or needle exchange, disease education. So those are just some examples of harm reduction, but really using that approach when we're working with folks. This is really a visual of some of what we've already said when we talk about housing folks quickly, helping people access housing quickly. It's also taking out this idea of someone being housing ready. And so if someone is experiencing homelessness, they're housing ready. We don't ever identify that this person is more housing ready than someone else. We recognize that some people may need to have different access to services and supports in order to maintain that housing stability, but we never look at it as someone is or isn't housing ready. To go along with that, Housing First doesn't look at access to permanent housing as a stair step or something that someone earns. So our traditional approach typically would identify that someone should first go into a shelter and then maybe into transitional housing. And if they do well there and they're, quote, compliant, or they're stable, or they're abstinent, sort of fill in those blanks, then they're rewarded or they graduate to the next level of housing. And again, in no way am I disparaging the importance of shelters as a key element in our system, and transitional housing as well. However, when we can, we want to see people be able to move right into that permanent housing without those stair steps. The stair steps themselves can be pretty traumatic, right? So if I'm in a shelter here and I go to transitional housing, it's on the opposite side of town. Now my kiddos have to change schools, or the clinic that I was using, Kay's clinic, is now not easy for me to access. So it's, you know, a 45-minute bus ride. And so those things that seem simple to many of us are really disruptive and further traumatizing. So again, not really having this mindset of someone having to be housing ready or earn their housing. So we've talked about some of these, but when we talk about supportive housing, we kind of have these key components. We do a lot of extensive training on these. We spend days talking about each of these different elements to different providers and stakeholders. But for today, just wanting to give you this snapshot. We've talked today about supportive housing and Housing First. It's working with households with those multiple barriers. So not only experiencing homelessness, but comorbidities around mental health and substance use and other physical health care, lots of different system involvement. So many different barriers that exist. We talked about that affordability piece being an important component. Also providing individuals and households with a lease. So when we talk about permanent housing, we're really talking about permanent housing. And so people have that opportunity and that dignity of moving in and having a lease that gives them that security that this is my home. Yes, I have responsibility as a leaseholder, but I also have protections as a leaseholder. And we center a lot of education and services around educating people about the lease process and what it is to be a leaseholder, and being, you know, following a lease and those sorts of things. But again, I think of it as having that dignity and protection of a lease that many people have never had that opportunity when it comes to a housing situation. We've talked about engaging in flexible and voluntary services. Supportive housing has dedicated staff, so dedicated on-site staff or dedicated committed staff to these projects that are providing that case management, those referrals, those connections. And then the other level of that service is then our clinics and our providers in the community, such as you on today's webinar. So making those referrals to health clinics, to mental health clinics. It might be recovery providers and managing those healthcare needs. So anything and everything that helps support that person in thriving and reaching their goals. Lots of coordination. One of the other elements is coordination between property managers or landlords and service providers and the tenant and the household themselves. And so really wanting to make sure that there's open door and communication so that when there are bumps in the road, folks aren't being evicted, that hey, we all have bumps in the road. How can we help support this person in staying housed? How do we help support you as the landlord or the property manager in your asset, which is your housing and obviously the rent that comes in. So there's a lot of a kind of a team approach there in helping individuals maintain their housing. And lastly, those connections to supports and connection with community. And so like all of us, we want to live in communities where we feel welcomed, where we can participate in the activities and the enjoyment of our neighbors and what our communities have to offer. And so helping people in supportive housing do the same, become part of their community in whatever way that looks. It may be work, it may be volunteerism, it may be using the parks and the recreation, but really being able to feel connected. Because at the end of the day, service providers are great, but having informal connections and building relationships and friends and connections is key to someone's longevity and maximizing and reaching their goals in life.
So thank you, Leah. I just wanted to note that we've had a couple questions come in. Would this be a good time to share those with you all? Get the conversation going. So yeah, one of our participants has noted that in work that they've done in the past with a nonprofit organization, with those who are unhoused or transitioning out of the criminal justice system, their anecdotal experience with transitional housing was often exploitative and unhelpful to them, especially in the Indianapolis area. And so this participant asks, have you all experienced or heard of similar concerns? And if so, are there resources or other avenues to address this when individuals find themselves in these situations? So I guess that's open to the panel. We'd be curious to hear your response.
So yeah, I jumped in chat a little bit. So, I mean, I think the short answer is yes, we've heard and witnessed similar things. A lot of transitional housing is privately funded. It is not an intervention that, for example, the federal government has prioritized. And so oftentimes it does rely on private funding. And what that means is oftentimes the transitional housing program is not regulated, or there may not be a lot of oversight over it. There are some that are funded publicly that do have, again, a lot more oversight and compliance, particularly around those that are fleeing domestic violence and things like that. But in the reentry space, this is a significant concern. And so I would kind of maybe point to two resources. So I think one, if somebody is wanting to kind of report a program that's, not operating well or being exploitative, that can be reported in a number of ways. One, to Fair Housing. The Fair Housing Center of Central Indiana can investigate any claims that may be around kind of discriminatory practices or practices that violate equal access or fair housing. The Marion County Reentry Coalition, MCRC, also does a lot of work and advocacy around housing programs specifically for those reentering from incarceration. And that's a great group to plug into, and Community Solutions locally helps support that work. So Lena Hackett and her team are a good connection there. And then for folks who are coming out of incarceration back into the community that just kind of need help with maybe identifying housing, doing some housing search and placement, there are some great resources both with Our Door Affordable Housing and HIP, Kay's team, to do some housing navigation support and housing acquisition, helping people find units that may, have relaxed restrictions around criminal background and things like that. There's an inventory tool called Padmission that folks use. It's kind of like a closedapartments.com, but where there's some very intentional landlord engagement work being done to identify units that may work with folks with criminal histories and things like that to find better housing options. So those would kind of be my response to that, and some recommendations for other resources.
Thank you very much. And Leah, sorry to interrupt. Please go on.
No worries, thanks. Yeah, I wanted to just end sort of the discussion I was having around the evidence for supportive housing and housing first. Particularly right now, we've got a lot of inaccurate and misleading information that's out there about housing first, and we really want to elevate that there's more than 20 years of research and dozens of studies out there that time and time again really support the evidence that housing first works. I'll put this in the chat a minute too. I referenced here our housing data tools section of our website, CSH website, links you to tons and tons of this research. But what we know across the country and across Indiana is that we see higher housing retention rates in some of the programming that CSH offers, or I shouldn't say programming, but some of the work that we do to help facilitate the development of supportive housing across 59 different operational properties and almost 1,500 units. We see a 93% housing stability rate amongst folks who are exiting homelessness into supportive housing. And that's just for this one particular initiative. When you talk to the Indianapolis Continuum of Care that Chelsea and Kay are part of, or the Balance of State Continuum of Care, which is the other 91 counties, you see similar housing stability rates when you look at aggregate data across dozens of HUD-funded initiatives for supportive housing and these models that I was talking about here. And so, the evidence is there to support that housing stability. Certainly fewer hospital visits and less use of crisis services, which both Kay and Chelsea have talked about, and that cost savings or cost neutrality. And so we see savings, or even if there's cost neutrality, if we're spending the same amount of money, let's do so to get people permanently housed, as opposed to cycling through crisis systems and shelters and helping them use that appropriate healthcare utilization. So I encourage you to access more data if you're interested to really see some of these outcomes. So I will pass things on to Guijo.
Thank you, Leah. And as you all saw earlier, I was experiencing some tech issues. So Anne and Gloria were gracious enough to take over my slides. So I appreciate that. If you wouldn't mind getting us started off on slide 3. And as you're pulling it up, thank you. I realize we're getting close to time. We're running out of time. So I'll probably be asking you to skip through a few slides, but I'll give you the heads up on those. So thank you. Just real quick, my why. My why is our shared humanity. these are interesting times that we currently live in. And being a man who identifies as Black and Latino, being seen and heard has sometimes been a struggle for me. And also as someone who's experienced my fair share of trauma, especially over the last few years, I'm grateful that my family and I have been able to be stably housed, have the space to work through it, and I'm still working through it. We know through our work that a lot of people we work with don't get seen and heard for various reasons. They're experiencing high levels of various levels of trauma, and don't typically have the space and or support to work through it. So that's essentially my why, our shared humanity. I've benefited from folks sharing their humanity with me. It's had a positive impact on me, on my family. It's been invaluable, and there's no substitute to seeing someone as a human experiencing difficulty and supporting them. And so it's, making it my business now in the position that I am, but in general in life, to create those opportunities for that healing to take place, however that may look. So I hope that we can all share in that goal going forward. Do you mind moving us to the next slide, please? So in the next couple slides, what I was hoping to talk about was healing-centered engagement, but I can't talk about healing-centered engagement without talking about trauma first. I do realize that I'm sharing this information with health professionals, so I don't think I need to go into the specific details behind what trauma is. But so actually, if you wouldn't mind moving us over to slide 7, just a few more slides forward, marginalized communities and trauma. Thank you. So as the slide says, trauma has no boundaries regarding age, gender, socioeconomic status, race, ethnicity, geography, or sexual orientation. However, historically marginalized communities are more likely to experience higher rates of trauma due to their social identities. People with BIPOC and LGBTQI2S+ communities can experience race, sexual orientation, and gender-based trauma daily through microaggressions and interacting with inherent biases, and have experienced generations of trauma and oppression. The trauma and oppression, complex trauma resulting from the ongoing experience of oppression and subordination, mental and emotional injury caused by encounters with racial bias, ethnic discrimination, racism, and hate. Many marginalized identities are charged with navigating through trauma plus ongoing experience of traumatic oppression crimes. So I mention all this to kind of set the table in terms of typically the way we've experienced trauma and serving folks with trauma is to look at those folks through the lens of their trauma, and not, as Kay and Chelsea mentioned earlier, as looking at those folks as people, as persons experiencing trauma, not defining them by their trauma. When it comes to marginalized communities specifically, and for the purpose of this discussion, I'm going to focus in on the Black community in Indiana and in Indianapolis. Could you move to the next slide, please? We just want to give you an idea of how the Black community is affected by homelessness. It's disproportionately affecting Black individuals and families throughout the state of Indiana. So these numbers are from the 2023 pink count that Chelsea put in the chat, the information concerning the pink count. But across Indiana, 9.27% of the population is Black, while statewide, minus Indianapolis, the data revealed that 27.5% of those experiencing homelessness are Black. And then in Indianapolis, 27.8% of the population is Black. And the PIT data revealed that roughly 52% of those experiencing homelessness are Black, 71% in families with minor children are Black. Those are pretty large numbers, and they make for some pretty stark reading. So most of a big chunk of our Black neighbors in Indianapolis and Indiana are experiencing homelessness, families as well. How does that affect how we serve those folks? Are we taking that into consideration when it comes to serving them in terms of their health and getting them housed and creating the space for us to lead them on the path to thriving? If you wouldn't mind going to the next slide, please. Actually, if you can move forward one more slide. Thank you. So just one more slide on trauma, and then I'll go into healing-centered engagement. Trauma can manifest itself in these kind of ways: disengagement of or lack of participation, lack of trust, preoccupations, aggression, ambivalence, anxiety and fear, strong emotions, guilt, shame or anger, overreacting, repetitive thinking, disturbed sleep patterns, isolation or being withdrawn, depression and feelings of hopelessness, and short-term memory deficits. I'm guessing all of you as healthcare providers have all experienced this kind of behavior from the folks that you're serving, and may have struggled on how to best serve the people who are experiencing this trauma. And so what I'm hoping to get you to focus on now is, next slide, please, one more slide forward, is to consider the healing-centered engagement approach. And that approach posits overall that instead of focusing on trauma-informed care is important because it highlights the need of the individual. But healing-centered engagement takes it a step further, posits that instead of the individual experiencing that trauma, that we're all collectively experiencing that trauma. Kay alluded to that earlier, and that when you see somebody on the street and they're experiencing homelessness, they're wearing clothes that they've been wearing for a long time, that they're struggling to communicate, they're not the only ones experiencing that trauma. You're experiencing as well. And then you're carrying that into your daily life in ways that you might not know how they're manifesting. And so we're asking you to reconsider how you approach the way you serve folks, and instead of focusing on the individual and that particular trauma, looking back on yourself and saying, okay, as a group, for example, as a team, how are we talking about the trauma that's being experienced by our clients? How is that reflecting back on us? What are we carrying into our interactions with those clients or those people who are seeking our services? And how can we create an environment where each touch point, each interaction is focused on healing not only the person we're serving, but also ourselves as the employees, the staff? How are we ensuring that we're creating that space? And the next slide, please. So just to double down on that concept, the healing-centered engagement is a holistic approach to trauma that involves culture, spirituality, civic action, and collective healing. Healing-centered engagement expands upon trauma-informed care through its strength-based collective view of healing that does not limit trauma to the experience of an individual and offers a more holistic approach to fostering well-being. Next slide, please. So again, the trauma-informed care approach challenges the deficit-based thought and language and behavior through the clinical application of understanding that the trauma occurred, and it builds upon the strength-based language that explores existing fortitude that's already present in all of us, and the ability to expand our identity and capability to impact our lives and the environment around us. Next slide, please. The key elements that I want you to take with you are: the healing-centered engagement focuses on transforming the conditions of the systems that causes the trauma through political action rather than just addressing an individual's experience, urges people who experience trauma to be agents in restoring their own well-being, considers healing as a restoration of identity, and focuses on the well-being people want rather than the behaviors or acting out that others want people to suppress, and supports service providers and tenants in their own healing. Now, wouldn't mind going to the next slide. What does this mean for you? Well, I think a good place to start would be understanding the community ecosystem that is causing the trauma. And so we put this slide up here to kind of give you a roadmap on the process of not only you as an individual, but as an organization. Here are some of the steps you might want to consider to start getting a better sense of what the challenges are for the people that you're serving. So starting with understanding the community ecosystem, then moving to understanding, communicating, reaching out to community champions, influencers, and leaders for buy-in and relationship building, connecting with the women influencers of the community, which I'm doing right now with the other panelists on the call. Joining forces, the next step would be understand, communicate, and involve. So joining forces with community serving organizations, opportunities for community scholars and citizen researchers to engage in the work, and engaging the youth through capacity building. And then the last but ever evolving step, which is understand, communicate, involve, and collaborate. So all the knowledge that you've gathered, how are you going to put that into action? Next slide, please. So we wanted you to be able to walk away with some actionable things to consider. But the number one thing for you to consider before you do that is being ready to pivot. If this work was easy, it would have already been done. And going forward, the work is definitely going to get rough. So it's important for you to be pivot ready. So don't allow perfectionism or fragility derail you. You'll encounter resistance both internally as well as externally. Internally, when that resistance arises, that means really leading into some self-reflection work, again, individually or as a team, that needs to be done. What internalized narrative is feeding our resistance, for example? If we're about equity and community well-being, what's holding us back from taking those next steps? Externally, remember the community has typically a pretty good reason not to trust us. We come to the table not only with our own history as an organization, but there are historical legacies around this country that have limited the ability of specifically Black and Brown and Indigenous folks of color to be healthy, have access to housing, engage in the healthcare system in a way that's beneficial to them. Are we considering that those legacies in how we engage with folks? Next slide, please. So a concept I wanted to introduce to you, if you haven't already heard about it, is targeted universalism. So basically, targeted universalism is an outcome-oriented. It serves an explicit and universal goal, and it shifts the discussion towards goals and outcomes among all groups. So I'll give you a quick example. Let's say that, let's use Black and Brown folks, the Black community in Indianapolis, for example. If your healthcare system in Indianapolis and you find through your data research that most Black males, for example, that come to the door at the emergency room have a much longer wait time to being served, then, let's say that wait time is 20 minutes or 30 minutes. And if you look at other data in terms of, say, a white woman or a white male, it's shorter, asking yourself, why is that wait time? Why is there a disparity in that wait time? But really, it's going back to, that's way too long that they're waiting to be served. What's the ideal wait time that we want everyone to be served? So using those kind of outlying data points for certain population groups, and then figuring out as an organization, what's the ideal that we want to have everyone experience, and what do we need to do to ensure that that happens? So it's, again, it's an approach that supports the needs of the particular. So in this case would be a Black male population, while reminding us that we are all part of the same social fabric. So we all deserve to have, 5-minute wait time. Why is it that these groups are experiencing longer wait times? How can we make sure that we're getting to a point where we're happy with the wait time that everyone's experiencing? Next slide, please. And so kind of mapped it out in terms of process for how to approach target universalism in your own system. So, first part would be establish a universal goal. Like I said, let's cut that wait time down, assess the performance relative to that goal leading up to that point, identify different group performances, assess and understand the different structures that are leading to those performances, and then develop and implement targeted strategies to make sure that we get all those groups up to the level that we want. Next slide, please. So again, you'll have access to these slides and this information afterwards, but I just wanted to kind of reiterate some of these points. So in brief, the overview for target universalism is universal goals, targeted processes and solutions, understanding a multidimensional problem to the eyes of different groups. There isn't one solution, but a wide array of nuance and diverse strategies that you can consider. Deliberate strategizing, truthing, and smart organizing. and tearing down structures and barriers that separate resources and people, building new ones and bringing them together. Next slide, please. So for you walking away, what I'm hoping that you'll start to consider is identifying what are the root causes of the challenges that you face or that the groups that you're serving face. Spending time there and figuring out what's behind those challenges. Then moving a step forward, talking about your motivation to address those challenges. How do you define what success looks like for your organization? Who are you going to be accountable to and why? That's another key part, because if you start going down this road of trying to address these challenges and it's not clear what your motivation is, not only to yourself, but to the community, you will eventually lose some traction along the way or buy-in from the community. So figuring out what that success looks like and defining who you're going to be accountable to can really exponentially grow not only the possibility for success, but the community buy-in and support and collaboration in achieving those goals. Are the inequities the result of long-standing systemic barriers, failings, and withholding of resources and or oppression? That's something to consider. You're not working in a vacuum. A lot of folks who are experiencing disparities and unequal access to the housing system or healthcare, they're coming out of a system that has framed it in a certain way that makes it much harder for them to access those resources. Are you considering what those barriers may be, and what are you doing to start addressing them? Next slide, please. Thank you. And so once you've considered the data, you started asking yourself these questions, here are some things to consider as well. How does your community make decisions about focus areas, goals, and strategies? The group should meet on a frequent basis and be empowered with authority to make decisions and move strategies forward. And these would be the targeted demographics that you're looking to address those disparities with. Ensure that the decision-making group is demographically representative of those experiencing homelessness in the community. Ensuring that you're including voices of lived experience of homelessness in those discussions. And I didn't put it on this slide, but a big part of that process as well, and we're big advocates of this at CSH, and I know that CHIP is as well, and so is HIP, is compensating the folks who have lived experience of homelessness whenever they're being asked to contribute to the design of any process, whether they're asked for their opinion on how something can be improved, compensating their time, whether it be through a stipend or through a gift card, or asking them, how would you like to be compensated for your time, and building that into your budget and normalizing that process of making sure you're compensating folks. These new structures that you'll put together must be responsive to the needs and lived reality of people who have previously been denied a seat at the table. So when are meetings being scheduled? How are people being reimbursed appropriately for their time?
Thank you. I just want to pause a second, noticing that it's 1 o'clock. And I know some of our participants will need to jump off. So I just wanted to thank everyone very much for joining today. And to please, if you have additional thoughts or questions, you may email those to me or to Gloria, and we will be in contact with our panel members to get those answered. If you would like to continue on and hear the remainder of the presentation, you are welcome to stay. But thank you for joining. Joe, please feel free to continue.
I will. I feel like I was rushing through, and I apologize, folks. I know time was short, but I feel like none of it can really be skipped. Well, with that said, would you mind giving me the next slide, please? Another key point to consider is that as you're doing your research and you're compiling your data, recognize that while your data and system folks tend to uphold data as a universal good, others have been harmed by it. So be mindful who's in the room. We often talk about real people and their trauma as numbers. So going back to the initial point of what Chelsea and Kay were saying, and Leah as well, these are real people. We have a shared humanity. We're not treating their conditions, the disease. We're trying to support the people who are experiencing this, and it doesn't define who they are. So keeping that at the forefront of your mind is a key point. Next slide, please. So relationship building, trust among your team members is a key part of this process. So relationship building is necessary and needs to be very intentional. What kinds of questions are we asking? How do we expect to gain from those answers? When people show up more authentically, we need to build in flexibility to adjust to their authentic selves. That's another key point. You know, folks who've experienced homelessness and or trauma may not feel comfortable sharing their authentic selves with you. How do you create that space for that to happen? And then build a team charter that focuses on the values of the group and the vision of their work. So that's the internal work of your team. Going back to the drawing board and say, okay, what do we need to do to put in place to ensure that not only the folks on this team can be authentically heard and seen, but this is how we approach every interaction in the community. And I would say, thank you for the next slide. So to further that work, in your day-to-day work, asking yourselves what hinders healing in your own space for you and your team and for the people you serve. How can you address them and rethink how to encourage healing for you and your team, as well as the people you serve? And the next slide are collective healing items to consider to center your work. So building empathy, build critical reflection and take loving action, encouraging dreams and imagination within your own team. That's going to translate to how you interact with the folks that you want to serve, fostering the we with shared language, and nurture peer empowerment and healing. And you can, I mean, these are also some things to consider for your team as they're going through this process for healing-centered engagement. And then the following slide has some resources for folks to dive in deeper with. Didn't get a chance to really get into much discussion. Still have a few people on the call. Talking about shared humanity. I'm a new dad whose 2-year-old's going to turn 3 on Saturday. I'm building up my dad joke collection. So I'm just going to drop a dad joke here to end this call. What is the favorite, what do ghosts play in soccer? What position do ghosts play in soccer? I don't see anything in the chat. No takers. Goalkeeper. It looks like we lost pretty much everybody though.
Well, thank you for sharing that, Guijo. And yes, there's so much information it's to share today. Very helpful. We appreciate you all being here. We appreciate your taking the time to.
So, before we end,
Go ahead,
I just want
William.
to get one question out there because
Please do.
there's an expression about my cup runneth over. Well, certainly this presentation, there was so much rich content that we could jump in a variety of different areas, but I'm interested in framing the conversation. Earlier, there was mention about policy changes. And so what policy changes are needed at the federal, state, and local level? And how do you propose for us to think about that and to support those initiatives going forward? Because there's just so much. And I love the fact that we need to see them as they see us. And so I like that community approach. But then when we're looking at a system, we're also looking at policies within those systems that literally keep some of this division ensconced in how we look at reality. So if you can address that from either one of you, that I think that would help us.
Thank you, William.
Yeah. And Leah, I'm sure you'll jump in. I mean, I'll share a couple. So, I mean, at the federal level, one of the big policy pushes is for additional investment and collaboration around housing vouchers, a reinvestment, if you will, in public housing and housing vouchers. And there's a great example of how the U.S. Department of Housing and Urban Development and the VA came together to create a set of vouchers specifically for veterans called HUD-VASH. And it brings healthcare components to housing. It's wildly successful. And we're asking for similar approaches between HUD and Health and Human Services to join forces and really bring those additional public housing investments to the table. That's a big federal policy issue. At the state level, there's 2 vital ones that we want to mention. One is we need additional advocacy and organization around housing first as a approach and policy. And it is under attack right now. So there's a group called the Cicero Institute that is moving away from housing first and really moving towards fining and sadly arresting folks who are sleeping outside, even when there aren't enough housing resources for folks. And they are present in Indiana. They have a lobbyist here. And so there's opportunity to actively advocate for housing first approaches and practices and funding to support that. And another big one is around the use of innovative healthcare financing. So we are one of the few states that doesn't use Medicaid waivers, the 1115 waiver or the 1915 waiver, to help support homeless services and tenancy supports. Many states have united again with healthcare partners, managed care organizations to utilize these Medicaid waivers to support this work, and Indiana has not. And so there's opportunity to do some advocacy at the state level around these kind of more innovative healthcare financing approaches. So those are a couple of the policy things I would mention that we'd love to figure out how to continue to organize folks around that advocacy.
Chelsea, one of the, here in Indianapolis, or I should say in the state of Indiana, and a lot within the Midwest, this area is a real estate investor mecca. And so I'm wondering if there has been any outreach to some of the investors locally, and many of our investors here particularly in the Indianapolis are foreign investors who've come in and are taking over many of our single homes. But has there been any conversation with the investors to get them on board so that we can move forward with some creative approaches?
There's some work being done around that, particularly through like Prosperity Indiana and the Hoosier Housing Needs Coalition. One, to kind of understand where these outside investors are coming from. And, you know, ideally you invite folks to the table to be part of the work and solution. And if not, if there are kind of bad actors coming into the community, how do we also strengthen some of the oversight and restrictions on folks that are investing here but are negligent landlords and not, you know, addressing habitability issues. Habitability is a big challenge here in Indiana in terms of enforcement of that. And we are one of only, I think, 6 states that doesn't have like a rent escrow policy where you can withhold rent if your unit is not habitable and your landlord is being negligent. You cannot do that in Indiana. The minute you withhold rent, you will be evicted. And so there's a lot of opportunity to both strengthen relationship with outside investors and also kind of tighten up the oversight and enforcement of outside investors that are not coming with the best of intentions.
One of the things I would add to that is just Indiana's poor history on evictions overall and lack of tenant protections, and what can we do to advocate at state level around better protections and regulations around those things, because we're second to New York City when it comes to the number of evictions, and that has just continued to increase. So
Thank you.
Great question. Thank you all.
thanks so much. I know
really
we could go
incredible.
on all day, couldn't we?
Yeah.
I mean, but
Great conversation. Well, this was really helpful. Thank you all for joining us. We so appreciate your taking the time to be here and share your wisdom and your experience with us. Lexi, I see you popping back on. Did you have a question or
Oh
something you'd like
no,
to
just wanted to say thank you. I learned so much, and yeah, you guys, it could be like a whole course.